Today's session is designed to arm you with current and accurate information about reform so that when you're talking to your hospital clients, you're educated about what's going on. I'd like to introduce Dr. Rebecca DeBowie, who is the Chief Medical Officer at HealthPoint Inc. here in Dallas, and is a healthcare consultant focusing on the hospital industry. Rebecca is a graduate of Harvard University, Yale University Medical School, and the University of Chicago Graduate School of Business, and is well-versed on the topic we're going to speak to today, which is healthcare reform and the implications it has on the hospital industry. We're fortunate to have Dr. DeBowie here today to give us her perspective on the healthcare system. Thanks for coming.
It's a pleasure to be here.
For starters, what is Obamacare?
Obamacare, as it is known by most people, is officially called the Patient Protection and Affordable Care Act. And we know that it's going to have great effects on the individual American consumer, but it's also going to have great effects on the hospital industry.
Before we jump into the effects of all this on the U.S. hospital system, can you tell us how reform will change the lives of American consumers?
Well, first of all, there are requirements for all Americans to have insurance or else face a penalty. The second thing is that in order to help them to get insurance, there will be health care exchanges from which they will be able to select the insurance plan that meets their needs the best. The third issue is that there will no longer be allowed any insurance restrictions on people with pre-existing conditions, and there will be no longer allowed to have lifetime caps on the expenditures made by any individual. So this means that people who have chronic illnesses or some kind of a serious illness will not face any discrimination. So again, for the individual, it should make insurance more accessible and easier for everyone to be able to obtain.
So this is estimated to provide coverage to over 32 million previously uninsured individuals by 2019. Would having more patients covered by insurance be a great boon for the hospitals?
Well, it's an interesting question. Historically, we have a large number of uninsured patients in the United States. Those individuals, when they go to a hospital to get care, unfortunately are what are officially referred to as self-pay patients, or what hospitals refer to as often no-pay patients. So yes, by having all Americans or most Americans covered by insurance, hospitals are going to have the benefit of having more people covered by insurance. However, it still isn't clear how well the reimbursement is going to be with those health insurance plans. And I'll give you an example, Medicare, for example. Today, hospitals recognize that for many patients coming in with Medicare, that payment is not going to actually cover the cost of care. So hospitals are still reliant, and they will continue to be reliant, on the individuals with the high-paying insurance plans. It is those patients that they use to then cover all of the costs of all of their patients in the hospital. So from the hospital's perspective, what this means is that they're going to have to continue to court those individuals with the high-paying insurance plans. And so this means that they're going to have to continue to promote high-end amenities, nice facilities, things like that.
Are these exchanges going to affect the way that consumers approach getting health care?
Well, yes, it will. The way that the health exchanges are intended to work is they will allow the individual to see all of the different types of health insurance plans that are available for them, so it'll be more easy for them to select the specific plan that is just right for them. And it is likely that they will continue to select in greater numbers what are considered to be called consumer-driven health plans.
Well, now that you've thrown that out, what are consumer-driven health plans? Tell us a little bit more about that.
Consumer-driven health plans essentially have two components. So the first is a health savings account or health reimbursement account, which the individual consumer uses to purchase routine health care. Sort of like a bank account. And then they have a high deductible health insurance plan, which is used to cover any kind of catastrophic illnesses or any very costly types of care that they might need to receive, like surgery or expensive imaging. And with these plans, what the individual does is they will have the opportunity to actually see how much they are spending from their health insurance plan. And what we've seen is that typically makes them more interested in looking for good value from their health care.
So what are the marketing implications for hospitals?
Well, in this case, because individuals are going to be more looking for value, so high quality at an affordable cost, or what they consider to be an affordable cost, hospitals will need to make sure that they very clearly articulate the value that they're providing to the consumer. They're going to have to make it very clear the quality of what they're providing and that it is at a cost that is worth the expenditure.
So what are the biggest changes for hospitals as a result of PPACA?
Well, the biggest changes for hospitals are that they need to act essentially with confidence in an age that is very uncertain, and they're going to have to move through this huge transition from being paid for quantity of care to being paid for the quality of the care that they are providing. And I'll give you an example. So, historically, if a patient is discharged from a hospital, and they're readmitted, that means they're being put back into the hospital within 30 days, the hospital would get reimbursed for that care. Great. However, there's a lot of question about whether or not some of those readmissions are entirely necessary. And so going forward, the trend is to say, well, some of those readmissions aren't necessary, so you're not going to get paid for those readmissions. So this is an example of where historically they had several admissions, they got paid for them all, but in the future they will only be reimbursed for that first visit and may not get reimbursement for the subsequent visits within the 30-day window.
Moving forward, what's the solution? How are hospitals going to get paid for quality of care versus quantity of care? How does that work?
Well, this is the $10,000 question, or in this case, the multi-billion-dollar question. It's not clear. There are a variety of different models that are being explored by the government and throughout the hospital and insurance payer industry. One of the models that we hear most about is the Accountable Care Organization. So in the Accountable Care Organization, there are several important characteristics of this. So the first is that payers will set certain cost guidelines, and so they want to make sure that costs are being contained. But then in order to ensure that it is not sacrificing the quality of care, they have a number of quality guidelines. And so the Accountable Care Organization, which is the hospital and their physicians and potentially other care providers, are responsible for maintaining their costs within a certain threshold, but at the same time demonstrating that they are providing quality care by performing at a certain level across a variety of different quality metrics. However, the research isn't clear that accountable care organizations are the way of the future. It's not clear that they are effective. So most likely what we're going to see in the future is a variety of different types of models. But again, for hospitals, they just don't know which model is going to be most successful and which model they're going to need to follow.
So everybody watching this is really going to want to know, what does this all mean for hospital marketing? Are there some opportunities here?
Well, regardless of which models are used, hospitals are going to receive reimbursement based on the quality of their care. That's the first important point. And the second point is that the quality that they provide, many of the metrics are going to be made clearly available to the public. For example, their 30-day readmission rates are made available to the public. So what does this mean for hospitals? Well, hospitals know that they have to provide quality care and in particular perform up to certain standards based on very specific quality metrics. So they're going to need to reach those metrics and then clearly communicate them to the public. They are also going to continue to pursue a variety of different quality programs. So, for example, JCAHO has a number of different, that's the Joint Commission on the Accreditation of Hospitals, has a number of different quality programs. Hospitals will continue to go after accreditation with those quality programs.
Are all the quality measures purely clinically based?
I'm glad you asked that question because it's not truly clear that they are. So, for example, in the accountable care organizations being run by the Centers for Medicare and Medicaid Services, which is CMS, There are a number of metrics that have to do with patient satisfaction. So, for example, satisfaction with the communications that they receive from their doctor, satisfaction with the timeliness of getting appointments and follow-up treatments, those sorts of things.
Does this measure clinical quality as well?
Not necessarily, and I'll give you a couple of anecdotes to make this hopefully make sense. So, for example, a couple of days ago, I was speaking with a pediatrician, and he said that particularly during the flu season, he has many patients coming in who want antibiotics for their children, even though there's not been a demonstration of a bacterial infection. And clinically, you don't want to give antibiotics when you have a viral infection. Not only does it not help, but it also leads to increased rates of antibiotic resistance. But he feels pressure to give the antibiotics because otherwise his patients aren't going to be satisfied. Another example, actually, interestingly, this morning, I met a pediatric orthopedic surgeon, and she said that her patients want 5 different opinions on every test, and they want to have their surgery done that week. Well, that's not always possible, and so she's feeling frustrated because she's doing the best she can within her schedule, and yet that leads to the potential of her getting dings on her patient satisfaction scores, which can then translate to decreases in the reimbursement if she's associated with an accountable care organization.
What do hospitals need to do in order to succeed in this new complex healthcare environment that we're talking about today?
Well, what we're seeing is integration. So there has been a trend over the last 10 years for hospitals to have some level of integration, and it's only going to accelerate. So when we talk about integration, there's 2 different kinds. We're talking about the vertical integration and horizontal integration. So for vertical integration, hospitals are, for example, continuing to purchase physician practices in great numbers. Historically, they did that in order to secure their referral channels so that they could get the high-end procedures in the hospitals. But now they're increasingly doing that in order to increase the cooperation and coordination with the healthcare providers. We're also seeing vertical integration as hospitals are looking at going way upstream and providing wellness programs and hiring wellness managers and such. And then also looking at providing long-term care, other sorts of those services. So really looking to have a presence across all different types of care. We are also seeing horizontal integration. So that means mergers. So hospitals are trying to obtain the economies of scale that they require, they think, in order to be able to effectively manage populations of patients.
So here we are sitting in Dallas, Texas. Can you give us an example of how something like this is happening in this market, which could certainly be happening in a lot of other markets that we're talking about?
Well, in Dallas, a recent good example of this horizontal integration is the merger between Baylor and Scott and White Hospital. It's a pretty big merger. Between the 2 systems, they will have a total of about $8 billion in revenue, 42 hospitals, 4,000 doctors, and 34,000 employees. So that's just one small, relatively small example of the kinds of mergers that we're beginning to see and likely to continue to see into the future.
What is the marketing opportunity with this shift from volume to value?
Well, what we've seen historically is that hospitals have tried to promote their, what I would call their latest toys, so the greatest and newest technologies that differentiate them from other providers. Going to the future, that will continue to be important in order to differentiate themselves from their competitors, but they're going to also want to market and promote the way in which they keep their patients well. So not just treat illness, but keep people healthy and well throughout their lives.
Dr. DuBois, thank you for your insight today on what is certainly a new and very complex subject matter, and we appreciate you sharing your insights with us.
It's been my pleasure. Thank you.